Okay, Chapter 9 covers auditory evoked responses, particularly the auditory brainstem response, which we'll talk about, and then vestibular or balance testing. So the ABR, or the auditory brainstem response, reflects activity of the nerve fibers within the auditory brainstem. And if you remember, the brainstem is that lowest level, one of the lower levels of the central nervous system. We call it a far field recording because we're basically recording a response deep down within the brain structure, and we're recording it from the scalp or the ears, and I'll show you that. So here you have a young lady who's being tested. Here you have the insert here and here for the right and then the left ear. You have a green electrode, which is your ground electrode, so there's no shock. Now remember, these are recording electrodes, they're not stimulating electrodes. So there's nothing going outward from the electrodes, they're only recording electrodes. Here you have an electrode on the forehead, and then you have an electrode here and an electrode on the other side. And this is from where the response is recorded, thus a far field response, because we're talking about a response from the brainstem, which is down here behind the person, obviously, and on the back. Here's some other equipment. This is automated. This is how it used to be. There used to be a ton of equipment that they would use in a hospital. Now these are used for kids for the newborn hearing screening. They have a cup transducer, so they put it around the ear and record the responses with these placed at different points like I just showed you. So with the ABR, we look at what we call the ABR waves, and we typically look for waves 1, 3, and 5. Now again, this is an undergraduate class, so you're going to get some basic information about this. If you go into audiology, it builds substantially. So we look at wave 1, 3, and 5, and so wave 1 is typically the nerve fibers near the cochlea. Wave 3 is more in that pons region, and then wave 5 is more in the midbrain, so you can kind of think about it as earlier response, later response, midbrain, and getting closer to the cortex. Here's a schematic, but this is what we look at. We look at the latency of each. So you can see wave 1 occurred about 1 millisecond, wave 3 about 3 milliseconds, sorry, and wave 5 occurred about 5.5 milliseconds. So the ABR, what I want you to remember is it all occurs within the first 10 milliseconds after the stimulus. And latency refers to the time following the stimulus at which you see a response. Okay? That's a post-stimulus response. We can use different types of sounds. We can use tones. We can use clicks. The main thing to remember is they're very brief or transient, okay? And we learned early on the effects of duration of the sound on the frequency content of the sound. And so there are some important considerations there, which are really beyond the scope of this course. So again, here we're looking for the waves. All of these factors can affect the auditory response, not just ABR. We have factors related to the stimulus, how the amplifier, and then how it's saved, basically, is what that slide shows. And we'll talk a little bit more about that when we meet in person on this. Again, we talk about the latency of the wave is the time interval from the presentation of the stimulus to the occurrence of the wave. And we compare latency responses to normative data. Amplitude is essentially the peak of the wave, how high in microvolts or millivolts the signal is. Okay, so how much strength of response. That's what we mean when we talk about amplitude. And we also have normative data for those. So right here you have the amplitude of wave 5 is 0.5 microvolts. Okay. Wave 1 is less, and it's supposed to be less. It's about 0.2 microvolts. And again, you have your latencies where they occur. And what we do essentially is we compare wave 1 latency, wave 3 latency, wave 5 latency independently, see how those are there. And then we look at what's the latency between 1 and 3. So how much is here between 3 and 5, and then a really important one is between 1 and 5, because that gives us a measure of how long it's taking the signal to be transmitted through the auditory system. And again, this is the ABR, just like OAEs, has really improved our ability to identify identify children, because we know if we get them in early intervention and we get them hearing sooner rather than later, usually within that first 6 months, the outcomes are much, much better. And there's a little baby having an ABR test done as a newborn hearing screening. We can also estimate thresholds. And so we're essentially saying, okay, here's a 6-month-old baby. We can't get regular behavioral responses, but we can measure and get within, let's say, 10 dB, 10% of their hearing thresholds. And we use stimulus. We use 500, 1,000, 2,000, and 4,000 hertz burst. Okay, so we can measure their auditory threshold at those 4 frequencies and do a pretty good job of fitting hearing aids on them. And here's an example. You can do it using a click as well, but let's say 4,000 hertz. So we're in right or left ear and we're wanting to measure 4,000 hertz. Well, you see how we measured this response at 85 dB. We have 1, 3, and 5. Okay. Then we go down to 50 or 60 dB, and then we get the response, even though it's not shown. And then we go down a little bit more, and I'm sure they just cut some of those out for the visual sake. But then you go down to 35, and look, wave 5 is still there. It's just shifted out a bit. And then they go down to 25, and then wave 5 is still there. Okay, so essentially what we're doing, once you go lower in intensity, you start to lose these other waves, but wave 5 should be present down near threshold. So in these cases, the threshold's probably around 25 dB or close to normal. Okay, so essentially what we're doing is reducing the intensity of the sound and looking for wave 5. And the level at which it stops and it's no longer present is approximately their threshold. So that was the ABR. We'll talk a little bit more about it in class. Again, this is undergrad audiology, so we just want you to have been exposed to these concepts, have a pretty general understanding upon which you'll build, particularly if you go into audiology. Now, the vestibular test battery is, is a balance assessment. Okay, it is an assessment of the vestibular system, which governs our balance. So we are, as audiologists, trained to provide diagnostic testing of the vestibular system. It's within our scope of practice. Some of the common complaints are lightheadedness, dizziness, imbalance, or vertigo. Now, vertigo, these 3 are not always truly vestibular or balance system related. They could be related to other things, but vertigo typically is always vestibular system related. And it's a sensation that the world is moving or you're moving. It's a false sense of movement. Okay, that's what vertigo is. It's not lightheadedness. It's not I get up and I get dizzy. It is true movement, the perception of movement even when there's no movement. When we're doing testing, we're looking for what we call nystagmus, and that's essentially when the eye is beating in a certain direction, okay? We'll eventually do some observation and you'll see, but the eye just moves and twitches when it shouldn't be, okay? And it can be right beating, left beating, it can be upward, it can be downward, but essentially it's an abnormal movement of the eye, and I'm going to show you some videos on that. This will not work on mine. Hopefully it will work on yours. If not, I will send you a direct link for some videos on nystagmus. But essentially what you see is the eye just twitching and moving when it should not. The test battery, most common is VNG, video nystagmography, right here, VNG. Basically the people wear, they wear these goggles. This device here monitors eye movement, and so there's times where the goggles are open, there's times where the goggles are closed. This little blue piece slides down to take away their vision. Here's another example where you can open and close the goggles. There's a camera in there, which is over here. You can see nice visual of the eye. The reason we monitor eye movement in vestibular testing is the visual system and the vestibular system are kind of, you can think of it as hardwired together. So as we move, the vestibular system and the visual system have to talk to each other to make sure, hey, this is where, you know, my head is in space. This is where my body is. Okay, let me adjust the eyes. Okay, so think of the visual and vestibular system as being hardwired together. Another test that we do is rotational testing, where we have them sit in a chair and we basically just swing them back and forth lightly. we rotate the patient, because remember, if you rotate in one direction, the eye should go in the opposite direction to kind of maintain your balance. And so rotational testing gives us an idea of does the eye move appropriately with movements in the body or head. And here's an example. So this person will sit in this chair, they will face forward, and then the chair will just rotate left and right, back and forth, okay? And we monitor eye movements when that's occurring. They call that rotational testing. Computerized dynamic posturography. The three senses that are strongly involved in balance are somatosensory. So here's an example of what I mean by that. So if you took your shoes off, took your socks off, and you stepped from carpet to hardwood floor to gravel, let's say you stepped outside of your house, you stepped onto the porch and then on, your feet will detect the environment for you. That's your somatosensory input, okay? And then the visual we talked about, and the vestibular. So all three of those interact to maintain balance. This is a posturography unit where we can systematically change those. We can have the person close their eye. Excuse me. You can have the person close their eyes and get different somatosensory input. You can adjust down here. You can change the angle of things. And so you have them harnessed in because you don't want them to fall. But this is called posturography, and it looks at all three of those senses as they contribute to balance function. VEMP testing is somewhat new. It was newer when I was in grad school in the early 2000s, 20 years ago. But essentially, it's an auditory evoked response that looks at different parts of the ear. And we'll talk more about it. But it's vestibular evoked myogenic potential. And you're basically just looking to assess whether or not you get this neck muscle potential that arises from different parts of the vestibular system. So VEMP testing, as we call it, it's not super common, but clinics who have a kind of comprehensive balance testing will include all of these. Most clinics just do VNGs and maybe a little bit of posturography. Some of this other stuff is not done. Like the rotary chair the rotational testing chair costs like $50,000, $60,000, $70,000. Vent testing is not as expensive. That posturography unit that I showed you is probably $150,000, so very expensive. All right, that's it for ABR and vestibular testing.